This presentation explores the healthcare systems of Eswatini and Papua New Guinea, two resource-limited nations with diverse cultural and geographical landscapes. We examine how they manage infectious and non-communicable diseases, equity in healthcare, and more. The goal is to inform global health stakeholders and identify adaptable, effective strategies for similar low-resource settings. Eswatini has a population of approximately 1.2 million, with a youth-heavy demographic due to high birth rates. HIV/AIDS affects 27% of the adult population, lowering life expectancy and creating a missing middle in age distribution. Cultural cohesion is high, though minority groups face resource access challenges. Socially, the country contends with orphanhood and stress on public services. Papua New Guinea is home to 10.3 million people, most of whom live in rural, isolated areas. The country is one of the most ethnically and linguistically diverse, which complicates healthcare delivery. Life expectancy is 65 for men and 69 for women, with significant regional disparities. Unique geographic and cultural factors demand tailored, community-based solutions. In Eswatini, health beliefs blend modern medicine with traditional healing practices. The monarchy and traditional authorities influence health behaviors. Gender roles often hinder women's access to care, especially in reproductive health. Social issues like child marriage and gender violence exacerbate health inequities, while urbanization adds emerging health concerns like lifestyle diseases. Papua New Guinea's health system is shaped by strong clan structures and spiritual beliefs, including witchcraft. These cultural elements affect care-seeking behavior and can lead to stigma or violence. Faith-based organizations are central in delivering rural health services. Public health messaging must be culturally and linguistically tailored to be effective. Eswatini operates a nationalized healthcare system dominated by the public sector. It faces workforce shortages, especially in physician density. Donor funding is critical, especially for HIV, TB, and malaria programs. Traditional healers are increasingly recognized in the formal healthcare system, and care is generally free at the point of service. Papua New Guinea has a decentralized health system with significant rural challenges. Community health workers are essential but minimally trained. The private sector is small and largely urban. Faith-based clinics provide vital rural services. Operational issues like drug shortages and weak infrastructure hinder service delivery across the country. Both countries aim for universal coverage but face challenges like workforce shortages and geographic inequities. Eswatini has broad availability of basic services but limited access for marginalized groups. In Papua New Guinea, logistical issues and language diversity hinder service uptake. Child, adolescent, and maternal health remain underserved in both nations. Eswatini spends 9% of GDP on health, but donor dependency and inefficiencies limit impact. Recent reforms target logistics and digital health. Papua New Guinea allocates only 4% of GDP, with issues of corruption and urban bias. Innovations like performance-based funding and public-private partnerships are being explored to improve efficiency. Eswatini relies heavily on nurses and traditional healers for primary care and mental health services. Efforts are ongoing to formally integrate these healers. In Papua New Guinea, community health workers and church-based clinics serve as the front line, delivering vital services in rural settings despite resource limitations. Eswatini grapples with the world's highest HIV prevalence and co-infection with tuberculosis. Pilot programs are addressing mental health and non-communicable diseases. Papua New Guinea battles high maternal and child mortality, malaria, TB, and gender-based violence. Innovations include SMS surveillance and alignment with national development goals. Both countries showcase how culture, resources, and policy intersect in shaping healthcare. Reforms must focus on equity, digital tools, and workforce development. Investments in supply chains and partnerships are crucial for building resilient, inclusive health systems capable of adapting to changing population needs.